Thank you very much for the kind introduction. First of all, I would like to thank you for the kind invitation to this beautiful meeting. And I was asked to talk about craniopharyngioma and to give you an overview and classification. I think about the classification you have heard already about the pathology. There are two types. So I would like to focus more on overview, and this overview, as I'm a pediatrician, is focused on the pediatric and childhood onset craniopharyngioma. As you can see on these pictures here, I think you all know that especially when there's supracellular extension of this tumor, the risk is very high that the patients develop severe obesity in a way which we call hypothalamic syndrome. And actually, I want to present you some of our data which we collected over the years, and I selected these data and results with special regard to the thought that I think these might be interesting from a neurosurgical point of view. So early on, 20 years ago, we wanted to know how high is the rate of severe obesity in this patient cohort, and this slide shows you the BMI SDS at the time point of diagnosis and yearly intervals after diagnosis of childhood craniopharyngioma. And first of all, we could see that approximately half of all patients, they were normal weight at the time point of diagnosis, and they kept their normal weight. And the other half of patients, they developed severe obesity, as you can see here. No? Okay. As you can see here. And what was also very surprising for us was that the most significant and steepest increase in BMI SDS occurred during the first year after diagnosis. Then there was a steady further increase of BMI SDS, and we were surprised to see that patients who were at risk for obesity were already more obese or had a higher BMI SDS at the time point of diagnosis when compared to patients without that risk. This led to the speculation that the pathogenic mechanisms for this obesity might be of impact and influence already before diagnosis and treatment. And so we looked at the records of these patients, and we looked at the symptoms in history. As you can see here, the most frequent symptom was headache, visual impairment, growth retardation, neurological symptoms, weight gain, diabetes insipidus, and disturbances of pubertal development. And on top of these bars, you see the duration in which these symptoms occurred before diagnosis. And you can see growth retardation and weight gain occurred pretty early before diagnosis of these tumors. So we asked the questions, do we have reliable data on weight and height in these patients? Because these are based on patients' records, which are not always complete. And indeed, we have these data because in Germany we have a national health survey, and at defined time points of life, U1 is at birth and U9 is at the age of 5 years. Weight and height is measured in every kid. And we were able to analyze in 90 patients who were later on diagnosed with childhood onset craniopharyngioma these data. We could analyze how was their weight and height development before diagnosis of craniopharyngioma. And this graph shows you the height SDS, the growth before and after diagnosis of childhood onset craniopharyngioma. And as you can see, once again, this is U1 at birth, you still remember. U9 is at the age of 5 years. The diagnosis was made at a median age of 8 years, and that's the yearly growth height SDS after diagnosis. And what we saw is that beginning with U6, at this point, there was a steady and constant and significant decrease in height velocity. And when you remember, U6 is at the end of the first year of life. So that's a really early symptom in history of these patients who later on were diagnosed with craniopharyngioma. What about BMI SDS? That's weight before and after diagnosis. And here you see that weight increased pretty late in history, between U8 and U9. That's about 5 years of age, and that's the diagnosis at 8 years. Already from a previous slide, that's the weight, how it developed after diagnosis and after treatment. Looking at the same data for BMI SDS with regard to the observation of hypothalamic involvement of the tumor, we could see that patients without hypothalamic involvement, they were normal weight before diagnosis, at diagnosis, and they kept their normal weight, whereas patients with hypothalamic involvement, they showed this steep increase in BMI SDS after diagnosis and treatment. Okay, when you ever want to know what's the reason for this, you have to look at patients with a long history, with a long-term follow-up. And actually, we have this cohort and this data because we are recruiting these patients in our registry since many years. And you see here up to now, or at that point, we had 671 patients with childhood onset craniopharyngioma in our registry, and we analyzed their outcome. And we did this in this. These are the total cohort, and these are the patients we analyzed, 280 patients who were diagnosed before 2001. We could look at overall survival, and we also looked at quality of life. And this slide shows you This slide shows you the 20-year survival rates in these patients. And we were surprised to see that in overall survival, as well as in progression-free survival, we saw frequent, even very late events in these cohorts after long-term follow-up. Looking at 20-year overall survival rates and degree of resection, we had a finding which was really interesting because when you look at the textbooks, many years ago there were textbooks who stated that's a neurosurgical disease, you do complete resection, then the problem is solved. However, when you look in our patients, we see that these patients here, when you look at progression-free survival, regardless whether they had incomplete resection or complete resection, they had similar progression-free survival rates, which means there is no advantage of cross-total resection when compared to patients with incomplete resection. And we looked at the impact of hypothalamic involvement of these tumors, and we were able to see that patients with hypothalamic involvement, they had a significantly decreased overall survival rate. So that's really a severe factor which causes death and fatal events in this cohort. We looked at imaging of these patients in 170 patients recruited in our study Craniopharyngioma 2007, and all pre- and post-surgical imaging was reference assessed. And we wanted to know what is the degree of hypothalamic involvement before surgery, what is the degree of hypothalamic lesions after surgical resection in patients with hypothalamic involvement, and what's the impact of such surgical hypothalamic lesions on BMI and quality of life 12 and 36 months after surgery. And in order to understand how we graded hypothalamic involvement, I show you this anatomical section. You all know, and you see it, that's the pituitary, that's the stalk, and that's the hypothalamus. And it's important for our grading system to identify the mammillary bodies, which you can see here, because based on our grading, any tumor or any lesion involving the mammillary bodies and the area beyond is posterior hypothalamic involvement, grade 2. Any tumor involving the anterior parts, sparing the mammillary bodies, are anterior hypothalamic involvement or anterior lesions, and any other tumors or involvements or lesions are no hypothalamic involvement. This is, that's examples for the imaging. No hypothalamic lesion. You see the mammillary bodies here. That's the situation before surgery. Here also you see the mammillary bodies, and also in this case you have a posterior involvement. You don't see the mammillary bodies, and that's the situation after surgery. Here you see that the cyst was relieved, the mammillary bodies are intact, and the hypothalamus, so no hypothalamic lesion. This is an anterior lesion where anterior parts of the hypothalamus were resected, and that's the worst case where the complete tumor involving anterior and posterior parts was removed, including the hypothalamus. And what we wanted to know, how is BMI SDS at the time point of diagnosis with relation to the grade of pre-surgical hypothalamic involvement? And as you can see, we were not able to detect any significant difference in patients without hypothalamic involvement, with anterior involvement, and with anterior and posterior pre-surgical involvement. This graph changes when we look at the change in BMI SDS during the first 36 months after surgery, in a way that patients who get anterior and posterior hypothalamic surgical lesions, they show a significant increase in BMI SDS during the first 36 months. And to give you an impression, this increase is in median 3 standard deviations, which means these patients get 50 to 80% weight during these 3 years after resection which causes anterior and posterior lesions. How does this reflect in quality of life? We used this PET-QoL instrument to measure quality of life. And as you can see in patients with anterior and posterior surgical lesions, in almost all domains except cognition, there is a worse self-assessment of quality of life. The higher the numbers, the lower the self-assessed quality of life is. Okay, these we are recruiting patients, and we know how many colleagues are recruiting these patients and referring the data to us. 54 recruiting centers. What do you think, in how many neurosurgical hospitals these 125 patients recruited in 55 clinics were operated? What's your guess? I can show you. In 50 centers. This leads to the speculation that there must be some centers who have very rare experience. That means they have actually, I would guess, 1 or 2 patients, and we looked at it, and others have more experience. And we could speculate that causes maybe also a diminished quality of treatment when you don't have experience in treating such patients. So it's difficult to assess experience. So what we did is we looked at patient load. We are postulating, and we know that we have recruited almost all patients in between 2001 and 2006, and we could identify 3 centers who treated more than 5 patients during this period. We had 24 middle-sized centers who treated 2 to 5 patients in this period, and 23 small centers who treated only 1 patient in 6 years. And what you can see, that's somehow a pity, in these very small centers, the rate of high-risk patients with hypothalamic involvement was significantly higher. Surgical hypothalamic lesions were higher, intended radical resection was higher, realized complete resection was also higher. So from this, we would conclude that small and middle-sized centers operated more frequently with the intention of radical resection in comparison to large centers. Small and middle-sized centers realized more frequently complete resections, and 40% of patients operated in large centers showed no postoperative hypothalamic lesions, which were detectable in 90% of patients operated in small centers. Looking now only at the high-risk patients, these are patients who had anterior and posterior hypothalamic involvement. That's a subgroup of these patients, and here we see once again that there is a significant difference in terms of intention to radical operation, which actually we have seen causes severe problems, and also in the rate of realized complete resections. So from these data, we would conclude that in small centers, 20 of 23 operated patients presented with anterior and posterior hypothalamic involvement, and that anterior and posterior hypothalamic involvement was only detected in approximately 50% of patients treated in middle or large-sized centers, so there's a difference. In large centers, complete resections were intended less frequently. In middle and small-sized centers, complete resections were intended in approximately 75% of all cases. The rate of realized complete resections was low in large centers. The rate of complete resection was approximately 1/3 in middle-sized centers and approximately 50% in small-sized centers. We also looked, does this have any impact on development of obesity and quality of life? And indeed, we published this, and we saw when we compare these centers, we saw a difference in a way that the delta BMI SDS, the increase in BMI after treatment, after surgical treatment, was significantly different when we compared large and small centers. And we also saw that in terms of quality of life, one PET-QoL domain was significantly different when compared between large and small centers in a way that patients treated in large centers had a better self-assessed quality of life. Okay, a lot of parameters where you never know what's really independent impact and what's covariable. So we did a multivariate analysis, and we wanted to know what are the independent risk factors for obesity at 36 months after diagnosis. And as you can see, we included hypothalamic involvement, tumor volume, intention to treat, realized degree of resection, surgical hypothalamic lesions, relapse or progression, and also sample size, as you have seen. And I don't know whether you know the publication. We found one factor, And actually, we're a little bit surprised, but we saw that it's hypothalamic involvement before surgical intervention. And these data led to our conclusion and postulation that that's a chronic disease. Whatever you do, you should think about that you have a patient which you cannot cure. You should do no further harm, and you should realize that this hypothalamic involvement of the tumor has a major impact of the outcome. What has changed? Okay. We also compared, that was very old data, Craniopharyngioma 2000, in a more recent study, Craniopharyngioma 2007, which was closed 2019. We also recruited patients that you see here. We compared 220 patients in the old study with 106 patients in the new study. And they were all rather comparable, but what changed, and I think you all know this, that the treatment modalities for irradiation changed in the way that proton beam therapy, is nowadays more frequently used in these patients. And you are, I am sure, interested in whether that changed anything in surgical strategies. And indeed, we saw that cross-total resection, the rate of cross-total resection was lower in the more recent study, and also the cyst drainages and the two-stage procedures were increased in the more recent study. So we think that's a development which needs time. And this also can be seen here. When you look at patients with anterior and posterior involvement, you know these are the high-risk patients. You see that in 13%, these patients had no lesion, no surgical lesion in the old study, and that in 35% of these patients, no lesion was found in the more recent study. What didn't change was the number of neurosurgical centers. As you can see, we had in the current study at that time point, 48 recruiting centers and 68 operating centers. There is one question which we are also interested, or that's always the same question, whether primary hypothalamic involvement has the major prognostic impact, as I've shown you in the multivariate analysis, or whether surgical hypothalamic lesions determine the outcome. So we asked the question, what is the effect of surgical hypothalamic lesions on outcome in a special group of craniopharyngioma patients? These are the high-risk patients which are presenting before a treatment with severe pre-surgical hypothalamic involvement. This you know already, I guess. These are patients with all have anterior and posterior hypothalamic involvements, huge tumors, but in some patients there is no lesion of the hypothalamus. In other patients there's only anterior lesions. In other patients the whole hypothalamus is gone. There's a severe lesion. And actually we had 169 patients which we could evaluate, and I would like to focus on these patients. These are the patients with anterior and posterior hypothalamic involvement before surgery. And they were treated with different strategies. In 21%, no hypothalamic lesion resulted. In 27%, these patients had anterior hypothalamic lesions. And in 52%, anterior and posterior hypothalamic lesions were detected by reference assessment. We looked at overall survival, PFS, BMI, and quality of life. And yeah, this simply shows you that the subcohorts of patients without lesion, with anterior lesion and anterior and posterior lesion were comparable in terms of gender, age of diagnosis, follow-up, and tumor size. What we could expect based on our design of the study, we saw more frequent incomplete resection in patients without hypothalamic lesions. That's expected. And we also saw that in these patients without hypothalamic lesions and residual tumor, as we suggest, more frequently irradiation was performed. First question is, how did they do in terms of progression-free survival, these high-risk patients? We did a statistical analysis and saw no significant influence, but actually, when you look at the curves, you see that there is a trend in a way that patients after cross-total resections leading to anterior and posterior hypothalamic lesions seems to have a somehow better progression-free survival. This is known, and I think that's not the goal, because we are looking for better quality of life. And we looked at the major parameter indicating hypothalamic syndrome, and that's BMI-SDS, as you know already. And we looked at it at diagnosis, 1 year, 3 year follow-up, and last visit. And once again, we have BMI-SDS. Oops, we have patients without hypothalamic lesions. We have patients with anterior hypothalamic lesions and anterior and posterior hypothalamic lesions. And once again, these are the high-risk patients who have anterior and posterior involvement before treatment. And what we see is that especially in patients with anterior and posterior hypothalamic lesions, there we have the most significant increase in BMI-SDS, which you have to realize is detectable in each group. Each group gets on weight, but this is most significant in this group. And what we also saw, and that was, I didn't expect this, that patients with anterior hypothalamic lesions have a similar weight pattern, weight development pattern, when compared to patients without hypothalamic lesions. So from this, we speculate that especially these lesions to the posterior parts of the hypothalamus in these high-risk patients, that's the crucial point for their development of severe obesity. And this is a very busy slide, shows you the data on quality of life in this cohort. No hypothalamic lesion, anterior and posterior. All patients had severe preoperative hypothalamic involvement. This is the situation, self-assessment, A and B, parental assessment, C and D. And as you can see, during the first year after treatment, there is no significant difference in terms of self-assessed quality of life in these patients, regardless of hypothalamic lesions. But when you look at 3 years, there are indeed differences as well in self-assessment as in parental assessment, which are relating to social function, which are relating to physical function, emotional stability and autonomy. And once again, the higher the values, the lowest self-assessed quality of life is. Okay. You all know in the literature there is a great discussion about centers of excellence, special places to treat these patients. In Germany, we have a federal structure, which is really difficult to support this. So what we decided to do almost 20, 25 years ago, we founded a network. And in this network, we are exchanging information. We provide reference assessment of all imaging, of all pathology, and many more things. And this is working as we think, but there's always the question, is it necessary? Is it useful? Is it successful? And we actually, that's a scheme of this, that's the technical aspect, the platform by which we transfer these data, web-based. But we also analyzed the question, does it make sense? Is it necessary? And here you see that what we did is we analyzed 229 patients. In these patients, we analyzed the primary surgery, the initial surgery, and we were looking at the surgical report of the local neurosurgeon, and we looked how he assessed the degree of pre-surgical hypothalamic involvement, of the degree of resection, and of treatment-related hypothalamic damage. And in parallel, we had the same data coming from the reference radiologist, also looking at pre-surgical lesions, a degree of resection, and treatment-related hypothalamic damage. And we also had the findings of the local radiologist, which were a little bit more spare, as you can see. But we mainly focused on comparison. How did the local neurosurgeons see the surgical results, and how did the reference radiologist see this? That was Dr. Warmuth Metz. She did it all over many years for all patients. Okay, and this slide shows you the comparison, how pre-surgical hypothalamic involvement was assessed by the surgeon and by the reference radiologist. And as you can see, that's the concordance rate, and that's the test. No, don't see it with this. That's the test which was performed, and the concordance was high, 92%, which means of overall 78 patients, in 72 patients, there was a highly concordant assessment when compared between neurosurgeon and reference radiologist. How was the assessment of degree of surgical resection when we compared it in this way? And here you see that the concordance was lower, 48%. Only in 43 of 89 cases, there was similar assessment of the degree of resection in a way that the surgeons assessed higher rate of complete resections. And we also looked for the degree of surgical resection as assessed by the local radiologist and by the reference radiologist. And as you can see, also in this comparison, there was a very low rate, only 44%, which means 26 of 58 cases, there was a similar assessment when compared between the two radiologists. And what about treatment-related hypothalamic damage? And here we saw that indeed there was also low concordance, 61%, in a way that surgeons assessed the lower rate of treatment-related hypothalamic damage when compared with neuroradiological reference assessment. The predictive value of treatment-related hypothalamic damage for prognosis was also assessed when compared, or we tried to assess it in comparison between surgeon and reference neurological radiological assessment, and we saw that direct comparison of BMI at 12 months between treatment-related hypothalamic subgroups assessed by surgeon and neuroradiologist was not possible. So we helped us and did the following. BMI at 12 months was available in 41 patients graded without treatment-related hypothalamic damage by the neurosurgeon. In 12 of 41 of these patients, no treatment hypothalamic damage was reference confirmed by neuroradiologist. In these 12 patients, BMI SDS increased plus 1.5 standard deviations during the first 36 months. And in 16 patients without treatment-related hypothalamic damage, as assessed by the neurosurgeon, treatment-related hypothalamic damage was confirmed by reference radiologist. And in these 16 patients, BMI SDS increased additionally 1.8 standard deviations. Total BMI increase was 3.3 standard deviations. So from this, I would summarize similar assessment of pre-surgical hypothalamic involvement by surgeon and reference radiologist, higher rate of complete resections as assessed by surgeon and local radiologist, lower rate of treatment-related hypothalamic damage used by surgical assessment, and high predictive value of neuroradiological assessment of treatment-related hypothalamic damage for sequelae. We also looked whether these concordances in these data were different in terms of center size, and there was no difference related to center size or surgical experience. So from this, I would summarize observed differences in surgical and neuroradiological assessments of degree of resection and treatment-related hypothalamic damage were not related to center size. Neuroradiological reference assessments is necessary for quality control, at least in multi-center studies. And the internet-based telematics platform is feasible and efficient in the German Craniopharyngioma multi-center HIT network. Last questions to you all. How many of 567 long-term survivors of childhood craniopharyngioma had no problems in terms of relapses, progressions, neuroendocrine deficiencies, or visual function after 5 years follow-up in our registry?
In your registry?
How many?
10%.
10.
5 patients.
Oh, you know the paper. 5 patients, below 1%. Okay. Childhood onset craniopharyngioma, I think, or I've shown you that decreased growth rate is an early symptom, which does not mean that all patients or all kids that do not grow have a craniopharyngioma. So the combination of growth retardation, headache, and vision, and also diabetes insipidus related symptoms should lead to the suspicion. Treatment should always be hypothalamus sparing strategy. Prognosis is impaired due to neuroendocrine sequelae, especially hypothalamic obesity. Further research on targeted therapy, and in one of the following talks, this will be highlighted by Karin. And treatment of hypothalamic obesity, and this is really a problem because there's no proven agent available nowadays, should be done. And what's most important, I think, for the patients is multidisciplinary experienced team treatment. And first and last of all, I would acknowledge the patients group, and that's really, really important when you have such a group, because Before Corona, they met once a year, and at each meeting they had a question, how is this agent? How is this situation? How can you explain this? And then you are standing there and say, that's a good question, we don't know it at all. And then you do the study, and 1 or 2 years later you present the data, and in the meantime they have further questions, and that's always a good source for the direction of further research. And I'd like to thank you for your attention.
Thank you for a fantastic lecture. We do questions immediately. And I will maybe start, if I may, with a self-critical comment from a neurosurgeon that, I try to think that I don't do that, but neurosurgeons sometimes operate and then never see the child again, or maybe once or twice after a year. And I ask in the audience, who of you has seen severe hypothalamic obesity after craniopharyngioma? A few, huh? So maybe you explain in few words, why is it so terrible? Some of us might think, well, they gain some weight and that's it. Do a critical comment.
Actually, many of these patients were operated by Professor Sørensen in Würzburg.
Okay, yeah.
And he also had the same experience. He did the operation, then there was MRI was performed. The MRI was perfect, no tumor, perfect. The radiologist said, optimal. You can publish it, and then we started this study, and I showed him the BMI SDS, and he said, "I'm a neurosurgeon, BMI SDS." And then I invited him to this meeting, and there he met 50 of his patients, and he came to me and said, "I didn't recognize them. I had never thought that this would be the person which I did operation on 3 years ago." And you have to imagine when you have a 14-year-old girl diagnosed with this tumor, getting operation. She's in the middle of puberty. And during the first 6 months after surgery, she doubles her weight. That's something. She stops any contact with her friends. All mirrors are removed from the house. And she tries to commit suicide, because that's something which is really... we are getting a little bit vague, but when you are in a special situation, as a kid, you grow, you have peers, sport, activity. Sleepiness is something that's no term in this part of our society. They are active, they should be active, and they are realizing everything is finished from one day to the other. And that's something which develops, and that's something which is sometimes really critical and is not noticed by the neurosurgeon, because you do the surgery and others do the follow-up observations.
Yeah, I think this cannot be emphasized enough. And we had the same reunions at Stanford where we both shared a common past, just with a few years in between. And I will say it very bluntly, but little fat, aggressive children who will make everything to break into the fridge was just a terrible sight. So it's very important. Other questions?
Thank you very much. I think this is a fascinating talk and very, very important talk. I'm somewhat comforted, but also, I'm a little bit disturbed that Germany has the same problems as Switzerland. That comforts me, but it also disturbs me. I wonder, in all these studies you showed the volume of the centers. Did you also look at the speciality of the surgeons? Because I know also in Germany, some centers have pediatric surgeons, others are adult surgeons who do transphrenoidal and craniopharyngioma. Was there a difference?
I'm certainly sure there is a difference, but it's difficult to analyze these data when you don't ask for them. We know that the large centers, we know which centers these are, and we know that these centers are pediatric neurosurgical centers. This we know. And we also know that the small centers, we know that there is no pediatric neurosurgeon. What we don't know, who has performed the neurosurgery, that's something else. And as you all know, that's only a very small subgroup. Somebody who just does pituitary surgery all day long, he has experience without operating on a kid. So that's very difficult to measure. So the only data which we had in our registry where the recruitment data, the patient load. So that's an indirect measurement, I guess. And it would be interesting to know this. And it would also be politically very, very strong and would lead to great discussions. But we don't have the data. Sorry.
Other questions? Yeah. We had Michel and then Oliver.
Thank you very much for this great talk. I was wondering, in your data, the transcranial approaches were the main way to operate these tumors, and the growing role of transpheroidal surgery, especially endoscopic, was promoted by Amin Kassam with his classifications. Do you see an impact already, or will you have a look at it, how this will change outcome?
What we see is that the rate of patients who are transphenidally operated under certain circumstances and with certain indications is growing, and we still have to wait a certain time to analyze what I've shown you, 3 years, 5 years outcome. But I would speculate, and then we have preliminary data, that the outcome is better because there is less hypothalamic damage using this route. Yeah.
Run back there.
Thank you. I actually had a similar question, but I will be a little bit on the other side, Michel, because transpheroidal surgery chose many times the lower craniopharyngiomas, which were not involving the corporal mammary bodies. So there is a bias in choosing, right? Now we're shifting more towards transpheroidal. That's true, me too. But the really hard ones, we do mostly transcranial, and so that's not really fair. So then you would need. But I have one comment. I'm sorry, it's not a question. It's really a comment, and it sounds a little bit like I want to show off here, but it's not, because when I started craniopharyngioma surgery myself, before I was just looking in 2008, I had really a lot of cases, and I knew about the obesity. We were talking about this, and we had a small series, I would call, where we said, okay, let's be aggressive on one side of the hypothalamus, but keep the other side untouched, so that maybe the function would help. Yeah. It did not. Yeah. So that, I just wanted to say that. So nowadays we just keep both sides untouched. So that's what we learned. It was not good to keep one side healthy or untouched. That's just a comment. But it's a learning curve.
I also can add, I didn't include data of Stéphanie Puget because I thought she would come. They have operated in neck by the same, actually this almost the same team over years with 2 different strategies, and they also could show when they do hypothalamus sparing strategies, neurosurgical strategies, that the results in terms of quality of life and endocrine outcome were improved. So this I haven't shown because I thought when she comes she would show it herself.
Thank you again very much. It was a pleasure, and I think with the time we will continue to the next lecture. So thanks again.